Good morning, everybody. Good morning, good afternoon, good evening, whoever you are, wherever you are. Thank you very much for coming in early for US people and for Tanzania. I know it's the middle of the day, busy, but we're grateful that you are able to come in. So we have people from Mwananyamala. Thank you for coming. We have Dr. Emma, we have Professor Brown, we have Dr. Msambichaka, we have Mr. Prank, we have Dr. Fabian Ngido. Very much for coming for the second session of basic fetal monitoring. And we know these 2 hours does not cover even 2% of what we need to know about fetal monitoring. But we're going to try to bring it as much as we can, make it as interactive as we can. So today is just going to be like more of interactive versus lecturing to people. So we have invited Mr. Jafari back with his 2 case studies. These are real case studies. And the purpose of today is to discuss those case studies and to learn through if as a provider, whether you're in the USA or you're in Tanzania, as a provider, when you see that patient, what exactly are you going to do with that patient? What information are you going to be asking about that patient? What are the care are you going to make? I mean, what decision are you going to make for care of that patient? And why did you make those decisions? So we're trying to break it down to make sure we can understand. So if that patient shows up in Mwananyamala, patient shows up in Buguruni, shows up in Muhimbili, or show up in North Carolina with Dr. Emma, at least we have basic care for this patient to cover, regardless of the technology. And that's the reason of this meeting today. So we do have Mr. Jafari, as I said, as the lead facilitator, and he was joining in. Hopefully we get in there. But then also we have our contributors. Thank you very much for agreeing. And then I get asked questions today as a student. So we have Professor Michelle Brown. I'm going to give them like 1 minute each to introduce themselves. So we have, yes, Professor Michelle Brown. We have Dr. Emma Kura Mugeri. We have Dr. Banera. We have Neema Mushi from Buguruni. And then we have our own, very own Mr. Jafari. Hopefully it's going to show up here. So to start with, I'm going to start letting the contributors introduce themselves. And then we go back to the case study. And then so Mr. Jafari is going to be presenting the case study. And then I'll give you the slide as well. I send it to the contributors. And then we let each of you provide the care. So there's no competition. There's no making other person feel faulty. You make the decision for what information you have, and then tell us what information are you going to look for to take care of this patient. So the care might be different, as I said, depends on the technology and knowledge, skills, experience, and whatever. But we want you to give us what you're going to do with this patient on your own facilities. And then if there's any best practice we can share, then we share and say, okay, if I had that patient in this situation, I'll be able to do A, B, C, D. So as I said, I'm excited to have this starting. So on my screen, Professor Michelle Brown, or your face. So if like 1 minute, explain so people know who you are.
Okay, good morning, thank you. It's nice to be back with all of you again. And just some background information, I've been a nurse for a really long time, always taking care of moms and babies. And I don't know why Dr. Gabon laughs when I say that, but so I do work with Dr. Gabon.
I love it. Anytime somebody says taking care of moms and babies, I feel good when I hear it.
That's the best thing to do, right?
Yeah. Cool.
So I do work with Dr. Gabon, and we teach students, we help students, and hopefully we are getting them to love moms and babies. So that's a good thing. And we talked last week about fetal monitoring, and it looks like we're going to talk about more care this week. So I'm excited about that because I like to hear how other people take care of their moms and babies, because we can all learn from each other. So I'm looking forward to our discussion.
Thank you very much, Professor Brown. Dr. Emma, you're next.
Yes, thank you again for having me. I'm excited to be here. And yes, I have been practicing obstetrics and gynecology for just over 15 years now. And it's a wonderful field, and I'm happy to share what I know, but also to learn from you. Yeah, because there's always something you could learn from somebody.
Yes, thank you very much, Dr. Emma. So Dr. Emma is from North Carolina, and Professor Michelle Brown is from Florida. Yay. Okay, the next person is Dr. Benella.
Hello, everyone.
Hi.
I would like to introduce myself and my team here. I'm Dr. Zavis Benella, gynecologist. I've been practicing for the past 10 years as a gynecologist. But today I have my two registrars who worked with me to prepare this presentation. I have Dr. Mugaru here. Last time she was in the presentation, and unfortunately he was.
Thanks, Dr. Benella. I learned my lesson. Go ahead.
We have Dr. Aminata. He also works with us. She also works with us in the department. We have also Dr. Zimbwe, our registrar in the department. So we have three registrars all working in the labor and the gynecology department in Manajamala. So I would allow Aminata to talk with Dr. Mugaru and then Dr. Zimbwe. They will be presenting for all of them.
Hello, everybody.
Hi.
Hi, my name is Dr. Aminata. I've been introduced. I work here as a registrar in the Obstetrics department, and I'm ready to learn today. And hopefully, we will benefit from our presentation that we have presented. Thank you.
You're welcome.
Hello.
Hi.
My name is Dr. Mugaru. I'll be joining you in the presentation and sharing our experiences according to practice, as how we're practicing here and how other people are practicing. So we're hoping through this we will exchange experiences and learn a lot of new things.
Thank you very much, Dr. Mugaru.
Hello, I'm Dr. Zimbwe. I've been here working in labor ward for almost 2 years. So hopefully we benefit from the presentation and to get new knowledge for better practice in our department. Thank you.
Thank you very much.
So Harriet, others have joined through their phones. They are not with us. They are in the different departments. I think.
Okay.
Yes.
Yeah. So after the meeting, if you can give.
Dr. Akida is in, and some others from the pediatric department.
Oh, okay, perfect. Yeah, so after the meeting, then if you can give us the names for people who are joining remotely somewhere else, if they didn't log in on themselves, so we can count and have accurate tallies for how many people are coming in. I can see Mananyama today. You make us very proud. Thank you, thank you. Is Ms. Nema here? I'm looking at my list. I don't see her. And I see Mr. Jafari is coming in. So we're gonna put him on the spot. Mr. Jafari, you're next.
Yes, can you hear me?
Yes, we can hear you. So we were just introducing ourselves like 1 minute or so, and then we're gonna give it back to you. So go ahead.
Hi, everyone.
Hi.
Yeah, my name is Jafari Rutavi, and as a midwife, and I'm also a facilitator for today's session, and I hope so we'll be together and enjoy the session as well. So you're most welcome.
Thank you very much. And we're looking forward to learn from your cases because I got so many questions. since it was purposefully set up
Okay.
that way, so you can be interjecting the information people are looking for. So as I explained before, I know you had other things to do in the beginning. As I explained, today's presentation, today's training is you're gonna read the slide of the case study, one of them, and then let every person chime in, asking you the questions that are missing, and then you fill in the blanks, and then you share the strips that then the care was offered on that patient, and then bring back to individuals, the contributors to jump in and offer their best practice, and then we continue with that. So, and when I send the slides, it has those posts, and because I'm gonna give you the screen to share with everybody else. And if there's any issue, then I have my screen also ready to go for the same thing. So before I let you start, I see Miss Neema just working from Buguruni. Miss Neema, just say hi and then and introduce yourself, and then Mr. Jafari is going to continue. Miss Neema, are you there? I saw her logging in on my screen, but no. But anyway, my name is Dr. Harriet Gabone, and I'm excited to facilitate this from the side and monitor all the discussion. That's great. So I am gonna let Mr. Jafari to take over. So I did make you the course so you can share the screen and start with the first slide, which is the case number 3.
Okay.
Or do you want me to share and then you can talk over it? Because I know you're freezing up. Mr. Jafari? Okay, I am gonna share this screen. And then I'm gonna okay. So now Mr. Jafari was supposed to speak, but I think the network or something is going on, but I'm gonna just read through it. But all the contributors have received this case study. Okay, we already said that our contributors today is Dr. Xavier Benella, who brought his team there, and then Dr. Emma Kuromugeri from North Carolina, Miss Neema Mush. Hopefully when she comes in, we let her say hi. I think she's logging in again. Professor Brown from Florida. So this is the pictures, you see them again when you start talking. So the case study number 3. So this case involved a 35-year-old, gravida 6, para 5005, who presented to the emergency department at 38 weeks and 4 days, weeks gestation with contraction every 10 minutes. She had not received any prenatal care with this current pregnancy, and we love these patients like that. Makes us think. And then her obstetric history was significant for the first pregnancy was gestation diabetes with medication independent. The 4th pregnancy was gestation diabetes again with non-medication dependent. The 5th pregnancy was diabetic non-medication dependent and preeclampsia with induction of labor at 37 weeks gestation. She denies headache, visual changes, right upper quadrant, and shortness of breath. Blood pressure was 210. The range, so the systolic blood pressure was 210 to 220, and the diastolic was 110. And then the heart rate was 56, respiration was normal. And this vaginal exam on the admission was 3 centimeters, 30% effaced and -3. And we know they're very, very high. Everybody who knows that they're coming to be induced, these patients, it's a -3, then you have to work so hard to bring that baby down. Anyway, at the bedside, the ultrasound was confirmed a viable fetus with a vertex presentation. So we hopefully is going to deliver this baby vaginally, and then measurement consistent with the gestational age at 35. Okay, so with this patient, as a nurse or as a doctor, what information do you need to know about this patient, and what information do you need to, I mean, what the thought process? I'm going to start with Dr. Emma. This is your patient.
Wow. Okay. So I think what's jumping out at me is the very elevated blood pressure. 210, I think he said that's in the severe range blood pressure. So first of all, I would want to know what is her height and her weight. And so I'm wondering what is her BMI, and is the appropriate cuff for her arm size being used? You know, sometimes you could use a small cuff for a very large lady, and then it falsely gives you a very elevated pressure. So I would want to know what is her body mass index, and is the correct blood pressure cuff being used to get her blood pressure.
Okay, and anything else? Because I'm going to jot down, and then we'll let Mr. Jafari answer those questions in combining for the answers from everybody else. Yes. Anything else for that case before I go to the next person, other than the BMI blood pressure cuff?
I would also want to know, I mean, is this patient, has she ever been on blood pressure medication before? Is this blood pressure a new issue, or is this something that she has had before? And was she taking any medication for this to control the blood pressures? I would also want to know how does the baby look at this stage? If mom is having severe range blood pressures, how does the mom look? So that's where I would start at.
Okay, thank you very much. I'm gonna let the next standpoint, you are admitting this patient. Is my name Mamush? She doesn't have a mic. Professor Brown, those good days that you started working as an labor and delivery nurse, this is the patient that she's telling you, and you're doing those vital signs, and you need to notify Dr. Emma about this patient, and she has those questions for you. What are the things that you, as a nurse, you think when taking care of this patient or admitting this patient?
Well, admitting this patient, you know, I'd definitely look carefully at her history. And she was preeclamptic with her last pregnancy. So does she know if that high blood pressure continued, or did it just come back with a pregnancy? And certainly I would want to make sure that the cuff size is correct, as Dr. Emma pointed out, so that we're getting the right numbers. And while I'm doing all of this admission vital signs and blood work, because she hasn't had prenatal care, so we would have a lot of blood work that we'd want to do, I would also be working very hard to develop a relationship with her, to keep her calm, make sure that we are putting in place how do we treat preeclampsia, that we would want a calm atmosphere, quiet atmosphere, dim the lights, and just start that off right away to see if we could get the patient to relax and help bring her blood pressure down a little bit.
Okay, thank you. So for example, since you are looking for the history, what kind of a question are you going to ask this patient? So yeah, you know that her previous pregnancies, yes, she has a history of preeclampsia, and now she comes out with that high blood pressure. And of course, you fix the blood pressure, for example. What other things are you going to ask this patient to get more information to help you with your care?
Well, I want to know, you know, has she seen a physician since her last pregnancy? What's her blood pressure been doing? How has she been feeling? Does she have any headaches? Does she have any visual disturbances? I would be carefully checking her reflexes. And then I would want to know some history about her other pregnancies. You know, how big were her babies? Did she deliver vaginally? Was she a C-section? Did she have a C-section? And then looking at the gestational diabetes that she also has a history of, we would want to follow that closely too, with some, you know, checking her blood sugar and just determining, are we going to have any problems with her blood sugar in addition to the blood pressure? We do have, the baby is doing fine now. It says a viable baby. gestational age of 35 weeks, but she thinks she's further along than that. Says she was 38 and a half weeks when she came in. So we know that there's maybe some growth restriction with the baby. So we want to monitor the baby very closely to see what's going on with that baby, because the baby does have some risk factors now working against it. It has the high blood pressure and possibly the high blood sugar. So we definitely want to keep a close eye on the baby also. This isn't somebody that we're going to let get up and walk around a lot in labor. They're going to have to be in bed, very closely monitored, whether it's on a fetal monitor, if you have it, or listening very closely with a Doppler.
Okay, excellent. Okay, I'm going to transfer that part to Mwananyamala crew. Dr. Banera, whoever wants to start, that would be great. Did you want me to pull your talking points? Mwananyamala crew?
Oh, we will just explain them.
Okay, that's fine. Go for it. Thank you.
Yes. So, according to our discussion, there were some things we wanted to know from the history, and there were some things we wanted to know in the examination of the patient. From the history, first we would want to know what was the complaint that made her attend EMD. Maybe she had had some episode of convulsion or loss of consciousness. We would be interested to know. We would also want to know the postpartum care during the last delivery, as Sister Michelle has explained. We would want to know, did the blood pressure subside? Did it go back to normal post-delivery? Was she monitored? Was she on under any medications post-delivery? We would also want to know if she has any other maybe metabolic disease, because her pregnancy history is positive for multiple gestational diabetes and preeclampsia. So we want to know if she has had any metabolic issues. And we would also be interested on why she has not attended antenatal care. That would probably tell us in the follow-up post this delivery, we could speculate what challenges she would face post-delivery follow-up. They could be the same challenges why she did not attend antenatal care. So those would be the things we ask in our history. Then in examination, we thought apart from just blood pressure, there are other things that we need to watch in any woman who is going to deliver. So we want to know the pallor, and because the blood pressure is also in the higher end, want to establish maybe she has some complications such as HELP syndrome. So we want to know if she's jaundice, she has any petechiae or purpura. We want to know that from her examination. We also want to assess the fetus closely by monitoring the fetal heart rate. As we've already seen in the ultrasound, there's a possibility of either wrong dates or IUGR. We would monitor closely the fetus. Apart from that, after rupture of the membranes, we want to know the LICA. With this pressure, the baby could be in distress. So we also want to know if there's any meconium stain in the LICA. Yes, that is all we want to know. And we also want to know her RBG and her urine dipstick for ketones and for protein.
Very good. Dr. Emma, did I see you raise your hands, or just my imagination?
No, I did not raise my hand.
Okay. I think somebody was coming in and he was next to you, so I thought it was. I know Ms. Nema Mush, unfortunately, she doesn't have an audio, so that's okay. Ms. Nema, you can write on the chat, you can write your comments there, and then I can read it as we go back to this question. So Mr. Jafari, if you can see, we do have the feedback from Dr. Emma Mugeli, we have Professor Brown, and we have the group from Mwananyamala asking or anticipating care for these patients, for that limited information so they have. So can you give us a little background on these patients answering those questions? I'm not sure if you heard all of them. I mean, I can give you probably a quick brief summary is from Dr. Emma. She was asking about the if the patient, what was the BMI for this patient? Was the right blood pressure cuff used since the blood pressure was in high range or severe range? Was the patient on medication like antihypertensive medication? Was the baby okay? Monitoring wise, from Professor Michelle Brown, the same thing, cuff size. She would want to know the history, and she had a few questions as a nurse, you know, when you're doing the intake for the patient, blood work, preeclampsia assessment, or symptoms, reflexes. She's going to be doing those things, vaginal exam, and previous deliveries, C-section or vaginal, since she has a history of diabetic and preeclampsia, and then the follow-up glucose if the patient was had. And then I think you were here when they're talking about from Mwananyamala crew. They have an extensive list of things that they will be asking themselves while they're trying to figure out this patient, since the history is very limited. And when we have patients who have not attended antenatal care, it's always like a puzzle, and you're running against time to try and answer those questions. So if you can give us the background of that case study, so to answer this question, that would be great. Mr. Jafari. I think you're still muted. Are they up?
How can you hear me?
Yes.
Oh, sorry, my network is not so good here. As I can hear from you, what you asked, this patient came with a history of high blood pressure, and actually she's known hypertensive. So by meantime, when she was admitted, her BMI, because he was not obese, she was not obese, and during admission, and the blood pressure was checked by using different type of BP machines, and it was just like that, which was ranging from 210 to 220 systolic, and the systolic was ranging about 98 up to 110. So when this patient came, after this patient was admitted, because she was in labor and actually was transferred directly to labor ward, especially with the issue that she was presented with, that she has reduced the fetal movement, and she was taken directly to labor ward. But she denied the issue of having headache and visual changes or right upper quadrant, those other features of severe preeclampsia. And where vital signs, as you can see, it was just severe hypertensive, and the pulse rate as well, it was a mild of a blood cardiac, which is also defined based on the blood pressure that she has. After cervical examination, the previous examination, the cervix, it was already started dilated, and the effacement, it was started to about 30% effacement, and the presentation was cephalic, and the baby, it was also a bit high, whereby the station it were -3. So what was done is bedside ultrasound, whereby the viable features were revealed, and with a cephalic presentation. Also, the measurements were still consistent with a gestation age of 35 weeks, and she had that's whereby the external monitor were placed to monitor the fetal outlet.
From Mwananyamala, they were asking about, does the patient has a history of convulsions, like history of seizure or complaints of?
No, she had no history of convulsion.
Okay.
Yeah.
You guys do any blood work? Because they were asking like a liver function testing, uric acid. Did you guys do all this urine testing, ketones and stuff?
Yeah, actually, as a baseline investigation that was supposed to be taken, those also were taken.
Okay.
And actually, because this case, it's a bit a long time, and we are as we are talking today,
yeah,
this patient it was going home. So the investigations were done. We're doing chemistry to see. So the chemistry were done to see those potassium level, LT, and there was elevated liver enzymes, but also she had no other features of that can reveal that maybe she might have any kidney injury or not. So by meantime, she was also on medication of antihypertensive.
Okay.
Whereby she attended clinic only 2 times, and she came as a referral from the primary facility, which is a low-level facility.
Okay.
And the good thing is it's whereby they were started antihypertensive already. So when she came in the hospital, she had Aldomet and nifedipine, which she were used. So at least they were started something from there. So by the time she came here, the blood pressure was still high, but though the tendency of taking those antihypertensive, it was not good as well. That's why we find that when she came on admission, the blood pressure was quite high.
Okay.
So and electrolytes, those were, as I said, is elevated liver enzymes, and something else that were elevated. It were I think I should have shared the results if it be.
No, that's okay. I mean, if it was done and it's elevated,
take some time to check for it. Yeah.
Yeah, that's okay. So I'm going to ask a quick question to Dr. Emma, and then we're going to go to the side. Now the patient was on the monitor. Dr. Emma, if the patient is requiring an antihypertensive during the pregnancy, have you used those medication before, Dr. Emma?
Yes, Aldomet and nifedipine. Yes, we do use them for oral blood pressure control. Absolutely. Now, if they do come in and they are already taking them, and then they're still elevated, that would make me now consider giving her intravenous antihypertensives. So something like IV labetalol or IV hydralazine. Those may have a faster impact as far as lowering her blood pressure. So I would definitely want to consider giving her some IV antihypertensives at this point.
Okay. And Dr. Benera's group, antihypertensive medications that you use, do you also use the same thing as Muhimbiri? Or also have you used the medication that Dr. Emma just said, the crew from Mananyama? Just a quick.
We use the same antihypertensives as Dr. Emma and Dr. M. Jafari said. The same.
Okay, perfect. Okay, so I'm going to share the screen now. This mom was put on the monitors. I know the labor and delivery people will be start cringing. Oh gosh. Oh, hold on a second. Oh, there you go. Okay, so now, Mr. Jafari, if you walk me through and then tell me if I need to go to the next slide or tracing, sorry.
Okay, so as you can see on the screen there, the findings that's being noticed when the patient was kept on CTG, then there is not a good movement of the, good chart of fetal athlete, because you can see there is some gap in there in between. But the good thing is whereby we just find the baseline fetal heart rate, whereby it's a 120, as you can see there, if it's seen clearly. So the baseline rate, it was 120 beats per minute, and there is some minimal viability, as you can see from the chart there. And the pattern, it's not good to determine, and because she had also none, there is no contraction that were noted, as we can see on the lower the below chart. There was no contraction by meantime during the monitoring of that patient. And also, as we can just classify it according to this finding. We found out that this is in category 3 because there is a minimal viability and the fetal athlete is within the normal range, whereby the baseline is 120 and they are not going beyond or above the normal baseline as 110 or 160. So because viability is there, and sometimes it's happening when the baby is also, it's happening when the baby is sleeping. So you might find this finding as well. And as you can see, because there is no contraction, so it's not easy to determine that if this finding, according to this finding that we have, was there any acceleration or deceleration. It's not so easy to detect that. So according to those findings that we can see there, undetermined fetal athlete pattern, which is it's not reliable or predictive of abnormal fetal status. However, there is a minimal viability without acceleration is also considering part for ongoing some hypoxia or possible development of some metabolic acidosis for this baby. Sometimes you might suspect if there is any placental insufficient in this kind of patient because of history of the patient as well, because the mother has high blood pressure, which is severe blood pressure, and this is also we can term it as severe preeclampsia with severe features, because the blood pressure only can determine that's severe features, despite of denial of having the headache or having a blurry vision or upper quadrant pain. So according to this scenario, the criteria for diagnosis of these patients were a severe preeclampsia or preeclampsia with severe features, and includes only onset of hypertension and blood pressure, whereby it goes above 160 millimeter of mercury for systolic and 110 millimeter of mercury for diastolic. And this intervention were done, this diagnosis were done after checking, after several measurements that have been taken at least within 15 minutes. And also after checking the proteinuria for this mother, it was a +3 as well. And there is no any other signing for severe features. So the plan, because this patient, according to these findings, so the plan it was to start magnesium sulfate because of severe features and high blood pressure, but also to continue with antihypertensive, whereby intravenous hydralazine were introduced because of the, if you can see her blood pressure of diastolic, whereby it was 110. So we are given hydralazine, and we are monitored closely to see if the blood pressure will be controlled or not. And this we are accompanied by restriction of giving IV fluids to these patients, as you can see the way she presents. And also, in case for the case of the fetal heart rate, the patient was kept on CTG and kept on monitoring, and for somehow we are just changing the patient position as well, and gave her oxygen so as to help the baby in circulation for the baby.
Okay, thank you very much, Mr. Jafari. So hold on for the next part. I'm gonna go back to our contributors. So let's go back to my nurse, Professor Brown. So as a nurse, you see this strip. What are the things that goes in your mind, and why did you choose what you're choosing to do next? Can you walk me through?
Professor, I cannot hear you.
Okay.
You're still mute.
Professor
Now can you
Brown?
hear me?
Yes.
Okay. So this is certainly a challenging patient, excuse me, and we would want to provide supportive care, make sure that she's getting her medications appropriately, very closely monitoring her vital signs, and providing a lot of emotional support, because I can only imagine how she must feel being in this situation. And that would just help her in the long run to feel better about everything if we can provide that emotional support. We'd have to closely monitor vital signs, blood work, make sure she's getting her medications on time, monitoring the baby appropriately.
Okay, thank you, Professor Brown. Naima, are you able to speak? From Buguruni, are you able to speak? I know the Buguruni group who came in. But...
Yes. Good evening.
Hi. Yes, go for it.
Yes. Good evening.
Hi.
Hi. I'm
So,
named from Buguru. What?
Go ahead. Go ahead. Mm-hmm.
Yes, I'm named from Buguru Health Center, working as a midwife. Yes, I'm happy to be with you guys.
Okay, so I know you came in and you didn't have the audio, but so this is the patient you put on the CTG and you find out the tracing like that. So as a nurse and midwife there, what do you do?
First of all, as a midwife, this patient, he needs close monitoring.
Okay.
Yes, taking vital sign. Make sure that the vital sign is stable. To monitor intake and output. Because this patient is restriction for fluids.
Okay.
And on this patient, I think the baby is not delivered.
No, not yet.
Monitoring. What?
No, go ahead. Go ahead.
Yes. And there's a drug administration like magnesium sulfates. Maintain dose. Because this patient is severe preeclampsia with severe features.
Yes.
So we continue to give the maintained dose of magnesium sulfates and the hypertensive drugs.
Okay.
Yeah. And the monitoring of labor, maybe she's in labor, and the so
Oh, you said that's all? Okay, so for magnesium, what is the loading? Do you guys do the loading dose and then maintenance dose?
Yes.
How much is?
Loading dose of magnesium is 14 grams. 14 gram is the loading dose. You give 4 gram IV and 4 gram IV and 10 gram each buttocks. 5 each buttocks to make it 14 grams. So if we want to give 4 grams of magnesium sulfate here in Tanzania, we take 12 mils of water plus 80 mils of magnesium sulfate. Then we give them slowly in IV for 15 to 20 minutes. And if we give the loading 5 grams of magnesium each buttocks, we give 5 grams in each syringe. We add one mils of lignocaine to able to reduce the pain, because this drug causes severe pain.
That was my next question. I'm gonna say that's 5 grams is brutal on the one batch.
What?
No, I said that's what I was waiting to say. You were giving her the 5 gram on one batch for the IM. Yes, I'm glad you guys put the lidocaine because that's a lot of medication. The 5 cc. Yeah, it depends if the patient has extra tissues. If they don't,
we give them a plus, plus 1 ml of magnesium sulfate. And after that, we continue with maintained dose of magnesium sulfate after every 4 hours, alternating buttocks.
Okay.
Yes, 5 milligrams after every 4 hours.
Okay.
The maintained dose.
Dr. Banera, so this is a Banera group. This is your patient. So what exactly are you going to do with this patient and why are you doing that?
If this patient attended at Mwananyamala, we would first give this patient or we'll do the bed rest, but we would cannulate the patient, catheterize, keep her at bed rest, and then we'll give her antihypertensives. According to this pressure, we'll start with the hydrolysate, as you said earlier.
Okay.
This stressing, we would just continue to monitor the fetal heart rate and give the mother antihypertensives together with magnesium sulfate to prevent convulsions.
Let's see. So my screen is frozen. So Mr. Jafari, can you continue with them? Oops, I'm going back already. Your interventions for this patient was done, right? And then if you can continue the next slide.
Yes. Yeah. So as you can see there, that these patients were also catheter were urinary catheter were also inserted and given a magnesium sulfate, so as I said before, as a prophylaxis, and hydroxyzine for blood pressure control, but was also administered. And a lab investigation were also taken to evaluate if this patient has preeclampsia or she is just PAH, but also the diagnosis also were supported with proteinuria, whereby it was +3, and the plan it was a panel whereby discussed about this patient because she's also a grand multipaler, and we're about to deliver by cesarean section. But this patient also, a previous pregnancy were just delivered by SVD. So the plan was to control blood pressure and to keep monitor this patient. As a matter of fact, that the fetal heart rate can be monitored because we have a CTG. So we are about to think on to control blood pressure first and to see how the fetal heart will going and how about the progress of labor as well, the way it will be. So at first, the plan it was to do cesarean section, as you can see on the presentation. That's whereby the anesthetists and were notified, and neonatal care units were also notified because of this fetal heart rate the way it is. So this obstetric anesthetic were notified because by any time, if we want to go for the cesarean section, so they'll be aware that we have such kind of patient because she has high blood pressure. So after 2 doses of hydralazine, this patient blood pressure were at least dropped, whereby the systolic blood pressure were 150 and systolic it was 70 millimeter of mercury, and this is after giving hydralazine, remember. So given that the fact that the patient was grand multipolar and she is in labor, so we can give her a chance to deliver normally. So because the contraction was not such enough, as you can see on the graph that we saw it before, the decision was to give oxytocin, whereby you give 1.25 international units and titrate it against contraction. Whereby if we get a contraction at that time, then we can even stop oxytocin and continue monitoring this patient because she was grand multipolar. So that's also done also for weighting the blood, the lab results as well. And the plan was to assess her again after 4 hours.
Okay.
So yeah, we can go on our next slides.
I'm going to ask Dr. Banera's group, what other things that you'll be thinking from what Mr. Jafari was talking about that could be addressing this patient? And then Dr. M, I'm going to ask you next. What other things that could be done at that time when you're doing the interventions, thinking of a C-section and doing labs with this patient, you're taking care of it? What other things should be coming in your head right now?
At our end, the first thing we would want to know the results from the full blood picture. Because of planning the cesarean delivery, she has a high risk of having thrombocytopenia because of her elevated blood pressure. But also she's blood para, so she's at risk of atony, and she has very high blood pressure, so we are assuming that she has decreased intravascular volume. So if any blood loss that should incur would result to hemodynamic instability. So we prepare uterotonics for delivery. We also would prefer to get a vaginal delivery. Thank you.
Dr. Emma?
Yes, I agree with everything that has been said so far. And also that tracing that was shown, I think I definitely want to see more of the baby's tracing. It almost looked like there was an acceleration there, but then maybe also a deceleration after the acceleration. So I'm not very sure about the status of the baby. I would definitely want to see more of the tracing longer, assuming that the baby was maybe category 1 or even category 2. I would definitely want to give her a chance at a vaginal delivery. But if it was a category two for sure, then I would highly consider a cesarean delivery.
Okay, so more tracing is like that one. So that's one of them.
Ooh.
And then
Oh.
next one is that one. That's 45 minutes later, I believe.
Okay.
Yeah.
And then that's 15 minutes. After that 45 minutes, that's the tracing.
Okay. So
Right.
got you. So that's an alarming tracing. I would hope maybe they had tried to place her on her side, get the uterus off the vena cava vessels so that there's more blood flow to the baby. Yes, this is the kind of patient that you don't want to just push fluids onto, given that she has preeclampsia with severe features. But if the interventions are failing, if the resuscitation interventions are failing, I would definitely want to deliver this patient by cesarean section.
Okay. Dr. Bernera's group, after seeing this tracing, what are you gonna do?
So as how it was explained earlier, that we, for this case, we would prefer more the spontaneous vaginal delivery, but according to the trend of the fetal heart dropping despite the resuscitation, so this for the safety of the mother and the baby, because we need to deliver her as fast as possible. So we need to make a decision for a cesarean section and prepare and have very good preparation for the risks that are in front of us for the cesarean section plan. So by that time, we could have already have the fetal results, make decision if she needs platelet transfusion, or if the platelets are okay, if the HB is okay, hemodynamically her pass rate is okay for anesthetic purposes. So this patient could be a good candidate for a cesarean section to have a safe
So when you guys are thinking of Dr. Emma and the Benera's group there, when you're thinking of either decision to deliver this baby vaginally or the decision to deliver this baby by C-section, do you communicate with the pediatric or neonatal on the other side just to make sure, because this baby is already compromised, mom is compromised. So do you prepare that team or you wait until the baby comes out and then call them? We can start with the
definitely.
Go ahead, Dr. Emma.
Definitely, yes, I would definitely alert the pediatrics team to be available because so many reasons. This patient's blood pressure is elevated, severe range. I'm glad it's better controlled, but it could be labile. So that's one. Two, she potentially also has diabetes. I think she has a history of diabetes in the other pregnancies. And that's one thing that I did not ask if anybody had checked a sugar level on this patient. Is she hyperglycemic or is she hypoglycemic? But that's also another reason to have pediatrics on board because, baby may be hypoglycemic when it comes out. And then three, the tracing is not a good tracing, so baby may need resuscitation. And then four, potentially this baby is actually 35 weeks in age and not even 38 weeks, or it may be growth restricted. So that's another reason to have pediatrics. So yes, I would definitely give them a heads up from the beginning. As soon as I decide I want to do a C-section, I am also calling pediatrics and the anesthesia team at the same time.
Thank you, Dr. Emma. The Mwananyamala group.
So we also anticipate that the baby may suffer from the distress that the baby is having. So preparations for fetal resuscitation or neonatal resuscitation needs to be done. So practically what we always do, we have a resuscitation table in the theater. By the time we're preparing that, we call the neonatal team in order to prepare also the environment to receive the baby for further management of the baby and for any incidents that may happen when we fail to resuscitate the baby fully in the theater. So that is always done.
Okay, so for Mr. Jafari now, so this baby is going to be delivered, and this is what you guys have. So can you walk us through?
Okay, yeah, the outcome, as you can see, that the baby were delivered by cesarean delivery because of, as you can see on the plastic chart, that's the graph, the baby was about a category 3 because there is some type of deceleration also there. And the baby were born, or it was 3 kg. And so sad that we had lost the baby, whereby the baby was called 0, despite of vigorous neonatal resuscitative effort. There was no heart rate and no, whereby resuscitation were done for 20 minutes, but unfortunately the baby died. So after discussion with the family, so we did a counseling to the family, and resuscitation were stopped to this baby. But also we are taking the according to the arterial cord blood that we are taking, it's revealed that there is a metabolic acidosis, whereby the cord gas, and it appears like that the infant had been exposed to significant hypoxia for a long time, and this involving metabolic acidosis before labor. And on the basis of mother history as well, because she has a preeclampsia and a prior pregnancy had preeclampsia, and she had most likely to had preeclampsia in this pregnancy, and with superimposed or a chronic hypertension that she had. So the obvious we diagnosed woman who was hypertensive during the clinic, and we actually supposed to give antihypertensive earlier so as we can control the blood pressure before she came into labor. And as you can see for this patient, she was not taken properly antihypertensive, as I said before, but also according to the findings that we have taken to this patient as measurement of the fetal heart rate, there was some kind of delay of decision for cesarean section, whereby as you can see, the outcome that finally we had lost the baby and we had a fresh stillbirth. I mean the early neonatal death, because we did the resuscitation there for this baby.
Okay, so just give me an idea. So since the admission to the time the mom is coming to deliver, how many hours are we talking about? And since we start seeing category 3 tracing to the delivery, how many hours there, or the time span?
As you can see, the tracing there, the patient were just admitted, then we had the trace for 45 minutes later on. Then after that, we had a 15 minutes and 10 minutes. So it's about 1 hour. The patient were just monitored in labor, before cesarean section were done.
No, wait a minute. You said from the time you put her on the monitor, she was monitored 45 minutes, what the previous tracing, and then 15 minutes. So
Yes,
that's total of
yes.
1 hour.
Then we
So
have 10
is that
minutes.
continuously 1 hour or segment of 45 and then time passes and then you put her back on the monitor for another 15 minutes?
It was continuous because of stress that I've seen on the glove.
Okay.
So it was a continuous monitoring.
Continuous, okay, for 1 hour, okay.
Yeah.
Wow. So things that we could have added, I know you added a couple of things, there could have been delay in decision making. And of course, these are now when we're discussing is hypothetical, because when you have this patient, probably you have more information than what Mr. Jafari is sharing. He's sharing what he's going to remember for that situation. So, and in real time, we know in OB, you are going to be doing the investigation over and over and over, right then and there with the patient. So you might have even more information if you're taking care of that patient. And always, of course, hindsight is always better than what actually is happening. So when you're thinking, I'm asking the Madanyamara's group, what are the things that you think you could have added? Not that maybe they will change your outcome, but just what are the things that you could have added in there to address what was going on with this patient? If this patient was on the monitor only for 1 hour and then the outcome was not the greatest, what could you have added in there to try and change that outcome? Madanyamara group. Anybody?
So okay, for me, I think from the start we saw the blood pressure was very high, but
Yes.
the pulse was very low, meaning even the placenta perfusion was not right. So this baby seems to have succumbed fetal distress for a very long time. Because as we can see, the CTG, the fetal heart was hardly not in a normal range. Because the normal we could say it's 110 to 160, but this baby had only one. The higher fetal heart was only 120. So the baby had fetal distress for a long time. And probably what we could have done better is to achieve the desirable heart rate, the maternal desirable heart rate. So as we said, like the IV fluids was to be given but cautiously. So achieving a desirable maternal heart rate or blood flow would have helped better to resuscitate the baby from the beginning. So, but also earlier intervention of this fetal heart. By this time, as you can see the CTG, there was a time the fetal heart was almost 80 something. The first drop. So this would alert, like after resuscitation, after resuscitating this heart rate of the baby, the fetal heart rate, to at least a normal value, that was the time to learn for the emergency cesarean section, and at least get a baby and resuscitate the baby, not as waiting for another fetal distress to be seen. So I think we could have run for cesarean section area when this fetal heart was dropping and later resuscitated to a better value. Then I think the plan could have been done area, the outcome could have been better.
Okay, thank you. I go from Madanyamara. Dr. Msambi-Chaka, I see your hand raised.
Hi, thank you. This question is coming from a pediatrician, so I apologize if it sounds silly, but I was just curious. You're saying that it took 1 hour from the time the patient came in the door to the time of delivery, or what is this 1 hour range? I'm just wondering, I think is 1 hour delayed? Is 1 hour considered delayed care? Because I'm thinking in 1 hour you were able to get labs, to give blood pressure medication to bring the blood pressure down to like 150, and you went to delivery like within 1 hour. Or am I missing something? So just curious if 1 hour is considered delayed care, or is this 1 hour from a certain, like, what are we counting the 1 hour from? My question.
Mr. Jafari?
Since she was admitted until the surgery were done, it took just 1 hour because of the surgery were just planned after I revealed that the finding on the CTG, it was not fine. Then that's where the plan of the section were done. So it took 1 hour to cesarean section.
So, I mean, working as a labor and delivery nurse for a while, when the patient comes in, so there is that time before I put the patient on the monitor, where it's recommended to put the patient on the monitor as soon as you have access to that patient, because you want to make sure the baby is doing okay. So
yeah,
when you admit that patient and get the vital signs, their weight, their urine sample, they're changing the gown, you put them on, you know, like, okay, you're gonna sit here, what's your name, whatever. That takes probably 5, 15, 20 minutes. Now the patient is already on the monitor. So I was assuming from the tracing, I was assuming that the patient was going to be, that 1 hour is because you start monitoring that patient for 1 hour on the continuous monitoring. But that patient was there even before that 1 hour. And I think that's, if I'm not mistaken, that's what Sambichaka is asking, that 1 hour from enter the door to the C-section.
From the first attachment of the CTG,
okay.
It comes from there, yeah.
Okay.
Because as if you remember, I said so. It might be also there is a significant hypoxia, which is also in boric acidosis, based on the finding that we had, which is whereby it might be earlier before labor started.
Okay. Okay. So Buguruni, I see you guys there. Can anybody has any comment if this patient was at your facility? What are you going to do? What could you have done different? Any comments from there? Buguruni?
No comment.
No comment? Okay. Professor Brown, as a nurse, was there anything else you could have added? And then I'm going to have Dr. Emma add to it. Taking care of the patient with the preeclamptic and stuff, anything that you could have done to add to it or ask the doctor?
You know, seeing the whole picture now, probably we would all think that we could have done the section earlier, but when you're admitting the patient and getting pieces of information one at a time, I think the decisions were good to get the blood pressure down, put the patient on the monitor, see how everything looked. If you had done a C-section earlier, the baby still would have been compromised had it lived, because it had so many risk factors and so much going against the baby. You know, it was really a hard call. An hour's not that long, but maybe in this case, an hour was a long time for that baby. I do have a question though. When you have a loss like this in your department, is there any follow-up for the staff, for the nurses and the physicians?
You mean follow-up?
Do you help, what do you do to help the nurses and the physicians deal with this, to decompress from this?
Actually, it's a very hard situation. And sometimes, you know, when you care the patient, if you care the patient, even half hourly, and you expect that this patient should go home with a baby and unfortunately you lost the baby. It's real hard, and somehow what we are doing is actually we are just counseling each other on the real situation that's happened. And because what also happened is we had some cases like this, which is the number is quite high. That's why sometimes it's not may take that nurse or a doctor or physician that's attending these patients for a long time to be displaced for a long time because of the numbers of such kind of cases that's happening.
Okay, thank you.
Yeah.
Dr. Emma, if you can add in, and then I have a couple of questions from the chat. I apologize, my screen was blocking the chat, so I didn't know people were sending the information in there. I'm gonna let Dr. Emma speak, and then we're gonna go to those questions from the chat.
Yes, I think this was a very challenging case.
Yes.
And given the maternal risk factors, you know, all the history that we've had, yes, very high chance that this baby was actually already compromised by the time mom showed up to the hospital. So I'm not so sure maybe doing the C-section half an hour earlier would have made a big difference. I'm not so sure that that would really have made a positive impact. However, if a patient is having a persistent category 3 tracing, I would definitely want to act on it at least within half an hour. Like if you are doing the resuscitation and it's not improving, I think within half an hour, I'll probably be heading to the back to do that cesarean section. So this is the kind of patient that I would have ordered, you know, stat labs when she came in, not just routine labs that take an hour or more to come back. And I would have acted a little bit faster. And I did have a question about the magnesium dosage. I think I heard somebody say they give, is it 14 grams of magnesium sulfate? Because what I know is we give a 4-gram load, and then depending on the mom's creatinine, you could give her like a 2-gram IV maintenance or 1 gram an hour maintenance. Could you guys clarify on that magnesium dose that this patient got?
I think that was the group from Mwananyamala.
So for us, as we know, there are 2 guides for magnesium administration. So for us, we are using the PRITZA guide, which is the loading dose. We give 4 grams IV, then 5 grams each buttocks. So it makes the 14 grams as a loading dose. So it's 4 grams IV, slow infusion, and 5 grams each buttocks, so making it 10 IM intramuscular.
Now, is that for everybody with preeclampsia with severe features, or is this if somebody's having an eclamptic seizure? Because it seems like such a high dosage of magnesium sulfate. Usually we just give a 4-gram load.
So we use that guide for because we give magnesium sulfate as prophylactic and also in patients with eclampsia already. So for loading dose, we give the same dose as to prophylactic patients and as a treatment for preeclampsia also. But after the loading dose, after the 4 hours, and after monitoring the magnesium toxicity values like the respiratory rate, urine output, and patella reflex, we continue with the maintenance dose of magnesium every 4 hours by giving intramuscular 5 grams magnesium sulfate each buttocks, alternative buttocks. So after the 4 hours of the loading dose, we give the 5 grams intramuscular, magnesium sulfate in one buttock. So in alternative buttocks, we continue with the magnesium indicated for the dosage.
Do you also check the magnesium level? And if you do, how often do you check when you're doing the maintenance? Because as you said, 14 grams on the loading dose and then 5 each every 4 hours is quite a bit. So do you check magnesium levels? And if you do, how often when you're maintaining the magnesium infusion?
So for us, because of the limited resources, we don't check for magnesium levels, but rather
magnesium toxicity.
Yeah, we monitor for magnesium toxicity by the parameters that I've said. So every 4 hours before administering another dose of magnesium sulfate, we always check for the respiratory rate as the complication of respiratory, the depression of magnesium. We also check for the urine output if the patient has adequate urine output, or if we suspect there is some insufficient output, then we always do the 4 hours creatinine levels. And also we look for the patella reflex. As we know, magnesium, if it's in high level, it may cause depression of the reflexes. So we just monitor those parameters because we don't have the availability to measure the magnesium.
Okay.
Thank you
Thank
for
you very
clarifying
much.
that.
I'm sorry, what did you say?
I'm sorry, I just had one more comment to say. I am glad I could see that the maternal heart rate was also being traced the whole entire time. I believe that's the one that's in the 60s.
60s, yeah.
Yeah, so that's wonderful because sometimes you may think you have the baby, but it's actually mom's heart rate. But I think in this case, it was pretty clear that mom was doing something different from baby. So that was a great thing that you all did, because somebody could come back and say, well, maybe you were tracing the mom all along and you thought you had baby and baby was already dead even before you did the C-section, but you guys had it well traced. So great job.
Thank you, Dr. Emma. So the questions from the chat, I believe is from, the first one is from Dr. Msabichak. It's asking, what is the target for blood pressure ranges that you want to have and how fast can you lower it? So yes, the patient shows up 220/110. What is the range you prefer the patient to have? And then when you're giving those antihypertensive medication, how fast do you want to lower it? And why? Can we start with Dr. Emma and then Mwananyama, you're going to be next?
Yes, so you definitely don't want, you do not want your blood pressure to be in the severe range. So ideally you want her blood pressure to be less than 160/110. And so if she came in at 210, you want to go down to at least, less than 160, but you don't want to drop it so low because a lot of these moms with chronic hypertension are so used to living with elevated blood pressures. And that's actually necessary to keep the blood flow through the placenta, to allow the perfusion. So you don't want to drop them so low. So I would say aim for between, 150 and 160, but less than 160, over, 90s to 100s, but less than 110. And you want to drop it down slowly over time. So I would say within 20 minutes or so. But keep in mind, if you're doing for example, IV hydralazine protocol, they do have, they tell you, give the hydralazine and then check the blood pressure again. I think it's in about 5 minutes or 10 minutes. And if it's still high, give another dosage. So I think if you follow the protocol according to the IV hydralazine recommendations, you should be okay.
Mwananyama, thank you, Dr. Emma. Mwananyama, what are the ranges that you want that patient to have? And I'm going to come back to Mr. Jafari.
So for us, we would manage the blood pressure by giving first the IV hydrazine as our first line according to the national standard treatment guideline. So we'll give the IV hydrazine first 5 milligram. Then we will monitor the blood pressure in 20 minutes, in 10 minutes, 2 times in 10 minutes apart. But our diastolic blood pressure, our desirable blood pressure should be at least below 100. So we will like to repeat the dose after the 20 minutes if the diastolic blood pressure still persists. But if it decreases to below 100, then we'll continue with the maintenance antihypertensive, like we continue with the levodopa, or even add nifedipine if it will require further. But first, we'll need to have a desirable diastolic blood pressure below 100 after the first dose or after the repeated hydrazine dosage.
Thank you very much, Mwananyama. Mr. Jafari, on your facility, using this case, what is the desirable blood pressure you could have want that patient to come in with? Or if this is too high, how low do you want to bring it down?
Actually, I'm not quite differently or far from the previous presenter from Manyamala, that the blood pressure that we're supposed to lower, at least it has to be within a normal, especially for these pregnant studies. If you have a pressure below 100, then and diastolic pressure below 100 and a systolic pressure which is below 160 for those patients who are severely high blood pressure, then from there at least you can continue monitor this patient with a normal antihypertensive, and you just take out from the hydrazine. So the time that we expect at least to control blood pressure is also equals Mwananyamala has done, as always did, and we usually measure blood pressure every after 15 minutes apart when the patient has given a hydrazine injection. And also after, the main thing that we want to achieve in lowering this blood pressure is to make sure that so the fetal status is fine, is fine, because as you can see in this case, this mother had also blood cardia, which is a sign also of means that the circulation is not fine, and there is a big possibility that there might be a hypoperfusion the placenta, whereby it can cause a stress to this baby, and due to hypoxia, it might rise. The baby will have metabolic acidosis, whereby this might cause the loss of baby as well if we delay notice that.
Okay, thank you very much. I'm going to go to the next question so we can try and get as many questions as we can. This one is from Samuel Nzamba. My apologies if I'm mispronouncing it. Yeah, I said this is a difficult case. We don't. Oh, what do you think we do? No, what was the cause of acidosis to this child?
Oh, okay. The cause of acidosis to this child is whereby this child were exposed to hypoxia for a long time. Yeah, that's why sometimes when the circulation of the mother circulation, if it's lower, and that's interfere the circulation also the placenta, and the baby will suffer for hypoxia for a long time, and that's why we can see there is acidosis there.
Thank you. And then I think the other question they have was like, did she actually have, I think you said the DM, I'm assuming that you said the diabetic mellitus in this pregnancy.
Diabetic.
Yeah, was this VBG also done to the mother?
No, the venous blood for the mother were not done.
Okay.
But also this mother had no diabetic mellitus.
Okay. So those are the few questions from the chat. So anybody has any questions? Thank you guys for your contribution. We were supposed to do the second case, but I think the time has gone. I think this one case, we learned quite a bit, and we're gonna find another day for that one. But we can all learn, as I said, sometimes it's easier to look back and say, I could have done this, I could have done that. Like what Professor Brown just said, when you are in it, you are doing it, the patient comes in, you get the history and stuff, blood work, you send blood work to the lab, so the lab have to give you the results. You're waiting 10, 15, 20 minutes to get the results. You have already lost that 20 minutes. And then you start doing something else. Maybe the doctor comes in and say, you know what, you add this liver function or whatever, and then, or the blood pressure is too high, give the medication, antihypertensive medication. Yes. You're waiting to see the result, that's already 40 minutes. So of course the patient is on the monitor. An hour, it looks like it's so long, but it's not long at all if you're in labor and delivery, because you're doing so many things at that time, staying an IV, doing this, you push medication, go and get the medication, bring it back. So communication definitely is important for this labor nurse or midwife who is taking care of this patient, to communicate with the physician, because as soon as that patient hit the door, everybody should be on alert. So all the orders can be ordered once, versus you order one and then 20 minutes later, you order the second things, because that you're already running out of time. And as I said, this baby was already compromised. We don't know if whatever we're suggesting now could have saved this baby. We don't know that. Sometimes you do everything you can, but unfortunately, baby does not make it when they're coming out. So it's a learning opportunity. So that's why we're just discussing, and just to make sure maybe next time we can be more observant and more attentive to all those subtle changes. That baby has category 3 for a while, yes, but for a while, that's 1 hour, looks like it's forever. But we are grateful that Mr. Jafari was able to bring this case study so we can discuss, and thank you for Mananyamala crew for adding to this discussion, and your details, responses, we appreciate that. Thank you, Professor Brown, for your contribution. Thank you, Dr. Emma, also for your analysis and contribution. I know Dr. Msamichaka had another question, and then I'm going to let the you guys just give us the last minutes of advice. Dr. Msamichaka?
Oh my God, I hope you can hear me. I think my internet is very unstable today.
No, we can hear you. Go ahead. Uh-oh. It's cutting off.
As outsider, I think it's hear me. Okay. I would just write my comment in the chat then. My internet is unstable this morning.
I can hear you now. Go ahead.
Okay, I was saying.
Oh, God. You start and then you disappear.
This very difficult case. And
we can't hear you, Dr. Msamichaka.
Okay. Write my comment.
Yeah, if you can write, that would be great. And then, because that would be giving us like at least 1 minute for every contributor, then that would be perfect. And then by then we can catch up with what you want to say. Let's start with Professor Brown. Any, as a nurse, experience and seasonedness? If in the future, what is the takeaway from this case study? If you have to get this similar patient like this, what are the things that you can take over from now and then help you prepare for this next person? So hopefully we can save the baby's life.
As I said before, I think all of the right steps were done, maybe faster. One thing we have to do is reach our moms before their due date and encourage them to get prenatal care, because so much was lost with the lack of prenatal care for this patient. And I know that's hard. It's so frustrating for all of us to have a patient come in that didn't get prenatal care, because now we have to do everything in 1 hour that we could have had 8 or 9 months to do as far as the care and the teaching for this patient. And then my other takeaway would be to debrief afterwards, so that just like we're doing now, everybody has a chance to sit down and talk about it and say, well, what would I have done differently? What could we all have done differently to maybe have a different outcome? And maybe there wouldn't have been a different outcome, but it should definitely be a learning experience for everybody.
Thank you. Thank you, Professor Brown. Mwananyama crew. Anybody?
Okay, so we are grateful for this opportunity. Like, we got to experience a scenario. This gives us some things to always anticipate. But I think we also reminder to each one of us that prior our cesarean sections, perhaps especially in these patients that we query fetal distress and all that, we should have at least a Doppler beside our theater tables, so that we could confirm what is still present that we suspected hours ago. So I think it's a reminder to every one of us that being in obstetric means saving the mother, saving the baby in all ways, in all manners that we can go. So thank you for this learning session, and we are glad to be a part of this and participate more in such discussions.
I'm going to hold you to that because there's 2 more sessions. I'm expecting you guys to show up again in the team. Thank you very much, Dr. Emma, and I'm going to have Mr. Jafari last. Dr. Emma.
Yes, I do want to say that, you know, these patients with the uncontrolled high blood pressure, these are usually very sick patients. And if you think about it, if mom has uncontrolled blood pressure, then even as the baby is growing in the uterus, with this severely raised blood pressures, it's going to affect how the placenta forms. The placenta is not going to be the healthiest placenta that there could be. So already baseline, baby is not going to be getting good perfusion because the placenta is not developed as it should. No wonder in this baby, it looked like it was already growth restricted. So these can be very sickly patients, and these are the ones that maybe we need to act on more quickly. As a matter of fact, I do remember when I was in training, that was many years ago, we kind of had something similar to this case, a patient that walked out of the street, no prenatal care, and she did have severe range blood pressures, and the tracing was also category 3. And we quickly rushed to do the C-section, but actually, you know, the baby came out already expired, even though there was a heartbeat before we went in. So these can be very sick patients. And as Dr. Brown said, we want to get them in for prenatal care to really control their blood pressures, because if you do control their blood pressures, the outcome will be much better than this one. So thank you for sharing this case, Mr. Jafari, but also I would hope that you guys can decompress, like Dr. Brown was saying, that you guys just meet and talk about how you feel and, you know, I don't know, de-stress, because this is very stressful. I cannot imagine experiencing these types of patients frequently, because I think they would wear me down and, you know, make me feel sad too. So I hope you guys are able to process everything.
Yeah, no, I agree with you, Dr. Emma. Yeah, when in labor and delivery, yes, we always focus on mom and baby, and we want to do the best we can to make sure we get a better outcome. So sometimes with everything we know, everything we have, and everything we could do, still the outcome is bad. It's draining because you feel like, okay, maybe I missed something, and you start doubting yourself. So if those things happen a little bit more, people get burned out and run away from the profession. So we want to make sure, like, yeah, you have that situation, like what Professor Brown just said, at the end of it, like debriefing, talk about it. What could you have done? Maybe we would have this. Maybe we could have ordered all the labs in the beginning. Maybe we should have standard practice that somebody with a severe preeclampsia or severe features, we identify on admission, the nurse notify, like I think Monanyama just said, the group said, make sure the doctor is involved early on, not just hang out as a nurse, just hang out with this patient and try to, okay, let me get all the information I need. No, if you are already in the beginning, say, okay, I'm going to do this and this and this, so can you come and help me here? Because I have this patient who I don't think everything is okay. So you shorten that time and then to try and give them a better outcome. So don't be shy to say, okay, I need to call the doctor soon in this situation so that we can put our head together and try and fix it up. So that was a good idea. We need to be able to be observant for that. Okay, so Mr. Pranka, you have your hand up.
Yeah. Yes. Asante Daktari Gaboni. Yeah, I just wanted to say that it's a very, very informative and interactive training session, and that I learned a lot from all of the participants here, and that I will definitely be here for the next one because these sessions are getting better and better. Asante sana.
Karibu, karibu. Mr. Jafari. Mr. Jafari, if you can give us the closeout. So now for what you guys, if you did the debriefing, then what are the lessons learned from you guys, so we can learn from what you guys discussed from your closing of that situation?
Okay, first of all, I would like to thank everyone for participation in this session. And actually, after a long discussion, that's why it was just taken as a case study to learn on how to monitor these patients from antenatally and intranatal as well. So as to make sure that every patient we have to save and have to make sure that every patient is having a safe delivery and a happy baby. So according to this case, as we can see that we had lost a baby, and actually the intervention that we have done is to make sure that every patient who came with preeclampsia or preeclampsia with severe features and eclampsia as well have to be monitored very closely. And if you have any kind of this case, you have to make sure also the NICU team are well informed about the patient. If we want to, if the patient is approaching to the second stage, or the patient will have to be taken for cesarean section. So this is a learning point for us, and actually it's helped us to improve on somehow in some cases. And according to this case, also in one way or another, it's trying to change also the practice that every patient who is coming with such kind of condition have to make sure that they put on monitor, whether either is using a CTG or is using a MOIL for continuous monitoring, so as to make sure that the fetus is totally okay. And if you have any doubt, then we have also ultrasound, bedside ultrasound that can be performed to rule out if there is any other cause of the fetal diminished or this decrease of fetal rate, whereby sometimes you might find there is maybe a rupture placenta, so then you can detect each area for this kind of patient. And my opinion according to this case is to make sure that we are taking a good care of these patients, and timely intervention is supposed to be done so as to save the life of this mother and babies as well. Especially for those who are in labor wards, they have to make sure that the leading that the leading that we say to these patients, especially for this kind of patients who are highly we said these complicated cases, you have to make sure that you monitor very closely, and you have to intervene according to the finding that you can see. As we all see that in this case, when we saw the first graph, everyone said that I have to retain this patient and monitor the progress of labor because it was in category 2. And after the second measurement and the third, everyone, it was like, oh, no, I was supposed to take this patient for cesarean section so as I could save this baby. So as you can see that we can't just rely on the just a single finding. We will need to have several findings so as you can make a good decision to this baby. But also for some hospitals like maybe Mwananyamala or Buguluni, but I know that there is no CTG, or it might be there, but some of them, they might not have a knowledge to interpolate it. But they can use even a fetoscope that we have to detect whether there is a fetal deceleration or there is acceleration in between the contraction. This is also give a picture that this baby is, how the baby is doing in the womb. So that's my opinion, and I would like to thank you again and again. And you have to make sure that you not miss this session because you learn a lot about the fetal monitoring. Thank you.
No, thank you very much, Mr. Jafari. In fact, you stole my question because I was going to ask Mwananyamala crew if they have the CTG and if they can monitor the patient continuous like what you just did. Because I said, yes, observation is the key and identification is even helpful you to, like anticipate what could happen to these patients, and quick decision could save life. But as I said, this time we know in labor and delivery, you can do everything you can, still the outcome is bad. However, but you did everything you could versus not doing enough. So, I mean, that was an excellent case study. And for Mwananyamala, do you guys have the same thing like what Mr. Jafari just said? As soon as the patient is arrived, do you have like maybe the physician on the maternal labor and delivery who can, like be around, or somebody have to call you from Mwananyamala?
Practically, we always call a physician when necessary, when there is some medical attention that is needed.
Okay.
But practically, we always attend the patient. Then when there's a need for consultation, then we follow.
Okay, perfect. Okay, guys, thank you very much. I appreciate for your contribution and giving us the time to come and discuss this case. This was a very rich and provided a lot of opportunities so we can share best practice. And then so we do have more OB sessions, 2 of them, in fact. One of them next week is the diabetic screening and identify risk for postpartum hemorrhage. And then the following week is also for postpartum hemorrhage, how to address an actual event of postpartum hemorrhage. So we are seeking those case studies. I know that I've reached out to a few of the midwives and the doctors to be able to get those case studies so we can work on it and then bring them here. And then if for those who wants to present, like what Mr. Jafari was the lead facilitators, we encourage you to do that because we want to learn from you as much as we want to learn from everybody else. So it's an learning opportunities. We're not laying blame. We're not saying, oh, you are late, you could have done this, because usually we know for sure the more information you get from the patient, that's how the care is going to be better. So we can't fault anybody else unless you are there taking care of that patient. So it's a learning opportunity for us. And as we say in the beginning and at the end, we are all wants to learn. It does not matter if you have so much technology or you don't, but we still want to learn from each other. So again, I thank everybody for being here. And so let's go and save those lives on those mom and babies and take care of them. So thank you, everybody.
Thank you. Bye-bye.
Bye, guys.
Thank you. Bye.
Bye, everybody. Thanks.
Bye. Bye, guys. Thank you, Mr. Jafari.
Thank you, everyone. Bye.
We have more stuff for you to work. Thank you, Dr. Emma. I'm going to send it for the diabetic one and for the postpartum one. So you guys know yourself. I've already started reaching out to you. So I'm going to do more of this interactive versus just the lecture presentation part. So thank you, guys. It was great.